Hi, everyone. Welcome back to our Next Gen Nurses free webinar series. My name is Rebecca Coulter. Might be a new face for you. I fill in a little bit on the nursing side, but I work in the professional education department here. I'm a registered nurse. I've been an ICU nurse for about 7 years. And so I stay really mostly in that CCRN certification world, but love to come over to the NCLEX nursing side and do some webinars over here as well. So if you're new to seeing me, that's a little bit about me and who I am. Today, we're going to talk about shock states, which is one of my favorite subjects. Being a critical care nurse, we see shock states all the time. We have clients that are in multiple different types of shock, sometimes at the same time. So lots of different things going on with these patients. So we only have 30 minutes today, so I'm going to try to move kind of quickly through this content. We've got 5 major shock states that I want to talk about, which really do cover all of them. So hopefully we can get through all this information. I'll make this a little bit interactive, but it will be a lot of just letting you know these main facts for these shock states. My goal is that you're able to leave today feeling like you're able to differentiate one shock state from another with some good key facts about each state of shock. We're going to get started here with talking about shock states in general, kind of rules that apply to all of the shock states, and then we'll break them down a little bit further. In the chats, if you're joining from Facebook or YouTube or you're here on Zoom, can you tell me where you're joining from, where you're at in your nursing school process? Have you graduated and you're studying for your NCLEX? Are you a new grad? Are you still in nursing school? Did you just get into nursing school? Where are we at? Okay, good. We've got Toronto, Maryland. I lived in Maryland for a while. Wisconsin. I was born in Wisconsin, actually. California, Nigeria. Awesome. Texas. Studying for NCLEX, graduate in August. Awesome. Okay. So we've got a lot of people kind of later in their nursing school career here, which is awesome. Congratulations. You're coming up on a very exciting season. So super happy to have you here. Um, Studying with Archer. Perfect. Awesome. Okay, well, let's go ahead and get started. Hopefully this little talk will help you feel more comfortable at shock states, which should help you on your NCLEX and in practice. Being able to recognize when your clients are going into a state of shock is really, really important. So let's go ahead and get started. First time preparing. Awesome. Good. We've got some great people here. Super exciting. Okay, so let's get started here talking about some shock basics. So this is kind of a wordy slide, so don't get overwhelmed. I'm going to walk us through it. But these are the things, again, that apply to every single state of shock, no matter which one we're in. This is kind of what the body is going through. Sometimes we get a little bit of variation when we start to talk about some of these compensatory responses. Those can vary shock state by shock state, but it's still kind of a good thing to go through how the body responds to a particular state of shock, no matter which shock state we're in. So shock basics. What is happening that kicks off this response in the body? What we're seeing is cellular hypoxia. Can someone tell me what hypoxia is? Just real quick. When we say hypoxia, what's going on for those cells? Yeah, not enough oxygen, right? Cellular hypoxia and hypoperfusion. So they're not getting enough of that oxygen. They're going underperfused. Great job, everyone. This is going to lead naturally to tissue death and organ dysfunction. Our tissues require oxygen. We know this. So there's a couple things that can lead to this hypoxia and this hypoperfusion. We can either have inadequate oxygen delivery, which comes down to a couple different things. Which body systems help with oxygen delivery? What would we be looking at if we've got inadequate oxygen delivery? Yeah, lungs and I think somebody said it, lungs and one other big one. Heart. Yeah, our cardiovascular system and our respiratory system. So we need our lungs to give us the oxygen, put that into the bloodstream. We need the heart to take that oxygenated blood out to the body. We need the blood vessels to be participating in that and getting all of that oxygenated blood out to the body. So inadequate oxygen delivery can be for 1,000 different reasons. We could have a lung problem, we could have a heart problem, we could have a vascular problem. And we can also see cellular hypoxia and hypoperfusion from increased oxygen consumption. So something's going on with the body that the body's using a lot more oxygen than normal, and those lungs and heart and cardiovascular system cannot keep up with it. So either one of those things can lead us to tissue hypoperfusion, and that is the necessary piece. No matter what shock state we're talking about, tissue hypoperfusion occurs. We have hypoxia occurring, tissues aren't getting enough oxygen, and it sends the body into a shock state. Now, once we are there, so that first stage of shock is tissue hypoperfusion. That's step number one. Then our body's going to start going through some other stages, and these are our 4 stages of shock. So initial is that tissue hypoperfusion. Then the body's going to do a pretty good job of recognizing that the tissues are hypoperfused, and they're going to start to compensate. This is that immediate response to the lack of perfusion. The body is going to do some things to try to meet these oxygen demands. So this is when we get into that stress response. A lot of this compensation response is kicked off by our sympathetic nervous system, our fight or flight. We're going to release good catecholamines like epinephrine and norepinephrine to do some things to try to get some more oxygen to the tissues. So classic compensation techniques that our body uses: increase in heart rate, increase in heart contractility. This is, all to increase our cardiac output because we don't have enough perfusion. So it makes sense. The tissues are dying for oxygen. Let's get the heart to beat more and give us some more oxygen. So we do that with heart rate and contractility to increase cardiac output. We can increase our vascular resistance to give us more blood pressure. We can cause some antidiuresis. Why would antidiuresis be helpful? Can someone tell me that? Or what is antidiuresis? Yeah, prevents us from peeing. We're going to hold on to water. And when we hold on to water, we're going to increase the volume in our intravascular space and increase our blood pressure. Volume equals pressure 9 times out of 10. So hold on to some water. We're going to release some steroids. This is going to lead to an increase in glucose levels, which is great because we've got a lot of cells trying to create energy. They are trying to make ATP. We need glucose to do that, so we can use some glucocorticoid release and increase those glucose levels. Like I said, those catecholamines are released, epinephrine and norepinephrine. They're responsible for that heart rate contractility and vascular resistance that's occurring. And then shunting of blood to vital organs. So we're going to pull blood away from our fingers and toes and our GI tract and give it to our heart and our lungs and our brain. Now, this is great. The body does a really good job of compensating, which is awesome. That's really great design that our body just knows to do that. It senses that we've got that hypoperfusion, and it's going to kick in with these compensatory mechanisms. Now, eventually, though, can our heartbeat, let's say while we're in compensation, we increase the heart rate up to 140 beats per minute to try to get more cardiac output. Can our heart just forever and ever beat at 140 beats per minute and never get tired and never get worn out and never start to fail? No. So these compensation mechanisms do fail. And that is where shock gets really, really bad because we've got these great compensatory mechanisms, but they're not going to last forever. And that's when we enter this progressive state of shock where these compensatory mechanisms start to fail. The heart is getting really tired. The lungs are getting really tired from breathing 50 times a minute, and the body's going to wear down. The tissues now have to transition from aerobic metabolism to anaerobic. So they're going into that metabolism of without oxygen, trying to still create an energy. Now, with that, we're going to see some lactic acidemia. Lactic acid is the byproduct of anaerobic metabolism. Anytime the tissues are having to go through their metabolic processes without oxygen, they're going to release lactic acid, and that's going to throw the body off in a lot of ways too. We don't like to be acidotic. We're eventually going to get vasodilation and increased capillary permeability due to tissue hypoxia. When we have this progressive tissue hypoxia, the tissue itself gets injured, and that's going to kick off an inflammatory response. And the two main symptoms of inflammation that I want you to always remember is vasodilation and increased capillary permeability. And when this is happening in a shock state, it's happening massively. We'll talk about this a lot with septic shock. So we've got this tissue hypoxia, injured tissues. Now we've got an inflammatory response. Now we're vasodilated, and increased capillary permeability is going to take all of that water that we pulled from that antidiuresis, and it's going to get it out of the blood vessels and put it into the tissues where we don't want it. So now we're really dropping blood pressure. As we continue to go through this shock state, our tissues are continuing to be hypoperfused. The mitochondria are going to start to really dysfunction, and they end up rupturing. And this means that no matter how much oxygen we try to get to those tissues, once those mitochondria rupture, they cannot take up oxygen. It's not going to help. And that will lead us to the refractory stage of shock. And this is the stage of shock that we never want to see our patients get into. We ideally are catching shock sooner so that we don't reach this stage, because what happens in refractory is that tissue has really died and there's no longer any treatment that's really going to work for these clients. Once we're in refractory shock, it's a really tough thing to come back from. We're going to see multi-organ dysfunction syndrome, which is MODS, and that's going to eventually lead to death, because these organs are just, they went too long without adequate oxygen. We didn't catch it fast enough. So what we're trying to do is prevent the progressive and refractory stages of shock. Now, sometimes we don't notice that shock is happening until we're already in the progressive, because that's when we start to see our patient be really a lot more symptomatic, because those compensatory mechanisms are starting to fail. So once we start to notice shock, we need to act fast so that we don't get to this refractory stage. Okay, how do we feel about those 4 stages of shock? Does that make sense? Awesome. I know we're moving fast. So let's talk about types of shock. There was 5 main ones. I'm not going to spend a ton of time on this slide because I want to get into the types, but there's 5 main ones that I care about. And there really are the 5 states of shock. So we've got 2 to begin with, and then 3 that kind of fall in one category. So our first state of shock that we're going to talk about is hypovolemic. This is when we lose a lot of intravascular volume. Then we have cardiogenic. So something's going on with our heart that's obstructing our cardiac output. That would lead to tissue hypoperfusion, right? We can't get oxygen out to the tissues. Same with hypovolemic. If we lose a lot of intravascular volume, we lose a lot of blood pressure. That's going to lead to tissue hypoxia and hypoperfusion. And then our third kind of category of shock is distributive shock. And this is where we're seeing a lot of that peripheral vasodilation. And that's what leads to that tissue hypoperfusion. So we can see this in septic shock, because with sepsis, we've got an infection, massive inflammation, and that's where we see that massive vasodilation and increased capillary permeability. Anaphylactic shock is kind of similar to septic shock in that way, except it's caused from an allergen, but we're getting that massive vasodilation and an airway concern. And then finally, neurogenic. Neurogenic, and we're going to break up these down later too. I'm just giving you kind of the quick and dirty here. Neurogenic is we lose our sympathetic nervous system tone due to some sort of injury in the central or peripheral nervous system, typically that spinal cord or a brain injury that makes it impossible for our sympathetic nervous system to work. And that means we are we're parasympathetic nervous system controlled. We're really vasodilated, we're rested, and that can be a state of shock due to that injury. So common characteristics for most types, we're seeing tachycardia, tachypnea, oliguria, lactic acidemia. It's all from that compensation. We're tachycardic, breathing heavier, trying to get more oxygen. We're not making a lot of urine. We're trying to hold on to volume. And we've got that lactic acid from the anaerobic metabolism. We're hypotensive. MAP is under 60. This can be an early or a late sign, because sometimes it's a late sign when our body's doing a good job compensating. We can keep that blood pressure up. But eventually, again, those compensation mechanisms are going to fail. Diagnostic tools, we're looking at our client presentation. And we're also looking at ABGs. Are they acidotic from that lactic acidemia? What does their carbon dioxide look like? Are they breathing off a ton of CO2 because they're really tachypnic? CBC, CMP. CBC helps us with hypovolemia. Do we have a blood loss situation? CMP, electrolytes. ECG for cardiogenic. We're looking at all sorts of labs. And goals of management, this really applies well to every single shock state. We need to restore tissue perfusion. That's our main problem. If we can restore some tissue perfusion before we get too late in these shock stages, then we can really optimize our client. What is a CMP? That's a complete metabolic panel. So that's what tells us how our kidneys are doing, how our liver is doing, and how our electrolytes are doing. And then, yes, management at the end of the day is very specific to the state of shock, but either way, we're trying to improve that tissue perfusion. So let's get started here with hypovolemic shock. We already talked about this. We have a decrease of intravascular volume loss. That's going to lead to a drop in blood pressure and tissue hypoperfusion. The main way that the body's going to respond to that and compensate for it is increased vascular resistance. When we don't have enough fluid in the tank, it's going to clamp down those blood vessels to try to get as much blood pressure as we possibly can out of the volume that we have. What would cause hypovolemic shock can be a variety of things. We can have hemorrhagic hypovolemic shock or non-hemorrhagic. So hemorrhagic is obvious. We've got some sort of massive bleed. We get, clients coming into the emergency room after a car accident. They're internally bleeding, or maybe we've got a visible bleed. That's going to be taking blood out of that vascular space, and we can get hypovolemic shock. Non-hemorrhagic could be from massive vomiting and diarrhea, too much NG tube suctioning, over diuresing someone. That happens actually more than I'd like to admit. Burns is a huge reason that somebody could go into hypovolemic shock because it causes such massive third spacing of fluid that even though that person didn't lose, they're not peeing more, they're not throwing up, they're not bleeding, but that fluid is no longer in the vascular space, and that's what matters. It doesn't matter how much fluid is on board. You could have a really, really swollen, edematous client, and they could still be in hypovolemic shock because that fluid is in the tissues and not in the blood vessels. So what are they going to look like? They're going to have these standard shock symptoms. Yeah, no albumin is another one. We've got nothing to keep that, no albumin to keep the fluid in the vascular space. Perfect. Orthostatic hypotension is really common when we've got a hypovolemia problem. So that standing in, or that blood pressure change for standing really is affected. Flattened jugular veins, meaning we don't have a lot of volume in those veins, and a narrow pulse pressure. Diagnosis-wise, we're going to see those shock symptoms, and we'll usually have some sort of presence of volume loss that we can see. Sometimes we don't know it's there yet, and it causes us to do a little bit more investigation. For instance, with that client that maybe is internally bleeding, but we didn't know it yet, we see these shock symptoms start to present. Their heart rate's really high, they're breathing heavy, we're having to increase their oxygen requirements, or their oxygen requirements are increased. And we think, well, what's going on here? We send a CBC and their hemoglobin has dropped 5 points. And we think, well, we've got to bleed. We need to figure out where that's coming from if it's not visible. And then the lab assessments are going to show us that lactic acid from anaerobic metabolism. Medical management for hypovolemic shock is probably the easiest of all of them. We're going to replace the volume. We're going to do this a couple different ways. If we have hemorrhagic, then we need to give this patient some blood. Just giving them crystalloids, IV fluids is not going to be sufficient. Sometimes when we have that non-hemorrhagic, we really don't need to give them blood. We can start off with some isotonic or hypotonic even crystalloid replacement. When we've got a non-hemorrhagic volume loss, we can sometimes see an increase in our sodium measure in the blood because it's really concentrated blood. We don't have fluid in there. So sometimes we'll start with hypotonic fluid replacement if we're seeing that high sodium. Typically, we're going to need at least 2 to 4 liters of this to reverse a shock state. Okay, I know we're moving fast. Let's talk about cardiogenic shock. So with cardiogenic shock, what we're seeing, it's kind of in the name, we're seeing a reduced cardiac output from an intracardiac source. And that's really important because if let's say we're in hypovolemic shock, we probably have a reduced cardiac output because cardiac output is a volume measure. It's liters per minute. So if we've got less liters circulating in the blood, probably have a less cardiac output, but the heart's not the problem. It's the volume that's the problem. So what is the caveat with cardiogenic shock is we're seeing that reduced cardiac output, and it's from something going on in the heart. Now, as the body tries to compensate for this, we've got this reduced cardiac output. It's going to do a couple things. Our blood pressure is lower, so it's going to increase our vascular resistance, give us some vasoconstriction, and try to get the heart to make more cardiac output. So how is it going to do that? It's going to say, hey, heart, beat faster. Now, the problem with both of those things is our increased vascular resistance and the tachycardia are going to worsen our cardiac function. They're going to put a lot of workload on that heart to have to push against really vasoconstricted blood vessels and have to beat really fast. So if we've got some sort of intracardiac problem that's causing this, and then these compensatory mechanisms get added on, we can really wear the heart down very, very fast. I would say of all the different shock states, cardiogenic is the one we want to find out about the quickest, because the compensation for it will make the problem so much worse so quickly. We really have to catch cardiogenic very fast. What different things can cause cardiogenic shock can be things like cardiomyopathies, which is just some sort of disease of the heart muscle. A myocardial infarction, so a STEMI or an NSTEMI, can cause this. When we don't get enough oxygen to the heart tissue, it starts to malfunction. Myocarditis, so inflammation of that heart tissue. Arrhythmias is a really big one. If we're in complete heart block and our heart rate is 25, our cardiac output is really reduced. If we are we're going into VTAC with a pulse or without a pulse, I mean, we're coding a patient, these are arrhythmias that would lead to cardiogenic shock really, really quickly. Another very common one is a mechanical problem or a structural defect, like an aortic or mitral valve dysfunction. We really rely on the heart valves to keep our cardiac cycle of systole and diastole going. So when we lose those valves and they start not opening and closing at the right times, we pretty much lose our cardiac output altogether. So these are things that we really need to fix really quickly. Some different assessment things that we'll see with this state of shock would be chest pain, narrow pulse pressure, decreased heart sounds. We'll have crackles from that backup of blood flow from blood not having good forward flow through the heart. It's going to back up into the lungs, can back up on the right side of the heart too, and we can have jugular venous distension. Diagnosis-wise, we'll see the symptoms, and we'll see an ECG showing some arrhythmia changes. Cardiac enzymes might look bad if we've got a myocardial infarction happening. Echocardiogram would show us how the heart valves look. When it comes to managing this patient, we want to be really careful with fluids because it'll put more workload on the heart to have to move that volume through. We're likely going to try to diurese this patient, but they're usually hypotensive, so it's a little bit tough. So we'll try to give them inotropic medication use. Give them a medication that's going to help the heart out, help it squeeze when it's really failing to squeeze. At the end of the day, most cardiogenic patients, yeah, dopamine's a great example. Dopamine, dobutamine, milrinone, major inotropes that we use. At the end of the day, this client is probably going to need a cardiac assist device like a balloon pump, an Impella, or ECMO, which we won't get into all of those too much. But that's really what they're going to need to bridge them to either a surgical procedure or just give their heart some really significant support to get through this stage. Okay, I know we're moving fast. Let's jump into our distributive shock state. So again, distributive is talking about peripheral vasodilation. And with septic shock, it makes sense because what are our two main symptoms of inflammation? Who can tell me? Vasodilation and good job. For inflammation, we don't always see a low blood pressure. Great job, Kelly. Yep, you got it. So vasodilation and increased capillary permeability. And when we're in septic shock, we are in a massive inflammatory response. So we are seeing massive vasodilation and massive increased capillary permeability. So the problem with septic shock is, normally when you get an infection, let's say you've got somebody who has a skin infection, they got some sort of wound on their arm. And we see that vasodilation response look like redness. It might be warm to that area because we're sending a lot of blood flow to that area. And that's all evidence that vasodilation and increased capillary permeability has occurred. We're trying to get white blood cells out of the bloodstream and into the tissues to help fight that infection. So those responses are really, really good for a localized infection. With septic shock, we're having this infection interact with the bloodstream, or it's just such a massive infection that we're seeing a really massive, uncontrolled response. So instead of just one area experiencing vasodilation and increased capillary permeability where we want it to, we're seeing it everywhere. And that's going to massively drop the blood pressure. So the body's going to respond with trying to get more blood flow because now we've got really bad blood pressure. Tachycardia, tachypnea for more oxygen, and increased contractility, trying to increase that cardiac output. Again, etiology-wise, we're looking at a massive infection that typically is going to interact with that bloodstream, causing the inflammatory response to be systemic or total body. This can happen with endocarditis is a common one. Cellulitis can lead to this. Pneumonia even can lead to this. Any infection can lead to septic shock. We see this with UTIs that end up with getting to the kidneys and causing an AKI. Assessment-wise, we'll see infection symptoms. That helps us dial in that this is a septic shock problem. We'll have that fever. We'll have an elevated white blood cell count or leukocytosis and tachycardia with that fever. We can also see disseminated intravascular coagulation. That's a byproduct of sepsis. It triggers the clotting cascade, and we get massive clotting and massive bleeding all at the same time. Diagnosis-wise, again, we're seeing those infection symptoms with shock symptoms that helps us dial in this is septic shock. We'll see elevated white blood cell count, glucose, and D-dimer. That D-dimer is what tells us that we might be in DIC. Medical management-wise, we want to get some blood cultures. And actually, I've got a better slide for that. We've got a bundle for this. So in the first 3 hours, once we start to notice that, okay, I think my patient's in septic shock, we want to draw some blood cultures to get what bacteria is in that bloodstream. Then start antibiotics. We'll start with broad spectrum antibiotics and transition them quickly once we get those cultures back to something more specific. Draw lactate levels, see where we're at with that lactic acidemia. And we're going to start fluid resuscitating them. They're super vasodilated out. So that means they've got something called relative hypovolemia. Even though their volume in their blood hasn't changed, we're not in hypovolemic shock, the volume's the same, but their blood vessels, instead of now looking like this or like this, they look like this. So relatively, we do not have enough volume. So we're going to give 30 milliliters per kilogram. As soon as we see that hypotension, and when we draw that lactate level, if it's over 4, we definitely want to give some fluid. So we'll start all of that in that first 3 hours. Now at the 6-hour mark, we're assessing that patient's blood pressure, determining if we need to give more fluid. If they're still hypotensive, we're looking at adding on vasopressors, which are going to help bring that basal tone to really dilated and constrict those blood vessels, which can be very helpful in this immediate stage. And we're taking another look at that lactic to see if the fluid helped bring the lactate down. A normal lactate level is under 2. We really don't want a lot of lactic acid on board, really ever. So we want to keep it under 2. If it's over 4, that's when we really know that we've got massive inflammation going on and a lot of anaerobic metabolism. Over the next 24 hours, we're going to give some corticosteroid. Why would we give corticosteroid to a septic shock patient? Yeah, inflammation, right? We know that we've got a massive inflammation problem. So corticosteroid is going to shut that inflammation down. So that's great. We're going to try to make sure we can figure out the source. Was this a pneumonia? Was this cellulitis? Where did this infection come from so we can treat it appropriately? Avoid hyperglycemia. Sugar and infection play really well together. So it's harder to treat infection if we're hyperglycemic. Assess that antibiotic therapy. Did our cultures come back? Can we make our antibiotics more specific? And then now we have a patient who's at risk for DIC. They're going to be in the hospital for a few days. Let's start some stress ulcer and DVT prophylaxis. Okay, good job. I'm going to go over just a little bit, so I'm sorry. I've got 2 more shock states. They're pretty quick, but want to make sure we cover them. So neurogenic shock. This is when we have some sort of injury to our central nervous system, the spinal cord, or a brain injury. And it affects the ability for the sympathetic nervous system to take over when it's needed to. So we lose our sympathetic response. We have a parasympathetic control. What do we know about the parasympathetic nervous system? When are we normally in parasympathetic nervous system control? What's like a phrase we hear all the time? Yeah. Z got it. Yeah, rest and digest. We're not running from a bear. We're not handling any physiologic stress going on in the body. We are just resting. Very vasodilated. Our heart rate is really low when we're resting and digesting. You know, your resting heart rate when you go to bed is much lower than it is when you're up and moving around during the day because we don't have the same demands. Well, now we've got this problem when we're in a spinal cord injury or a brain injury where even when we need our sympathetic nervous system to give us some vasoconstriction or a little bit of a higher heart rate, we don't have that balance. We lose it completely. So that's why this is a distributive state of shock because we're in a vasodilation tone. This is going to lead to that low blood pressure and tissue hypoperfusion. Now, assessment-wise, the main thing I want you to remember with neurogenic shock, other than that we're in parasympathetic control, is that we have bradycardia. This is the only shock state with bradycardia. Because we're in that parasympathetic control, we've got nothing to make that heart rate beat faster. That compensatory response that we have with every other shock state is lost because that's all the sympathetic nervous system that's causing that compensation. So we have bradycardia. And yes, we can we have digestion. We've got lots of blood flow happening to organs that we don't really need that blood flow at. Warm pink skin because we aren't normally we're pulling blood away from our extremities and sending it to those vital organs. We're not doing that when we're in parasympathetic control. So we've got pooling of blood in the extremities instead of shunting away from the extremities. Diagnosis wise, we'll see these symptoms with someone that we've got an inkling that they had some sort of injury. I mean, a lot of times we get the patient in and we know that they're there for a spinal cord injury or for a brain injury. And then they start to develop these symptoms and it's very easy to put two and two together. CT and MRI is what's going to tell us that we've got some sort of spinal cord or brain injury. Now, management-wise, IV fluid resuscitation because we're super vasodilated out. So it's the same thing with that septic shock deal. And then this patient's likely going to require vasopressors. Again, they're so vasodilated. They need some, what's the word I'm thinking of? Synthetic sympathetic nervous system because we can give norepinephrine and epinephrine, which are those catecholamines that are released by the sympathetic nervous system. So we'll just give them the synthetic forms. And ideally, we'll figure out how to manage their spinal cord injury or their brain injury and get them out of this shock state long term. Finally, here we have anaphylactic shock. This one is probably my least favorite state of shock. It definitely counts as a state of shock, but the treatments are just different than others. But it's pretty simple. We usually know how to manage anaphylaxis. This is again a severe immune response, kind of like septic shock. So it's leading to that massive inflammatory chemical release. And specifically leading to airway swelling. This is from allergen exposure to a specific allergy that your client has, and it's a severe allergen response. Manifestation, we're going to see kind of similar things. Hypotension from all of this vasodilation and increased capillary permeability, airway narrowing, and facial and tongue swelling. Because of where we're normally the client's getting exposed to that allergen, it's from them eating something. So their mouth and throat area has such a larger inflammatory response. And that's why we get facial and tongue swelling, all that third spacing that occurs. It's just now all occurring in a really important location, which is what gives us all of those airway concerns. So yes, very common with penicillin, what other things can do this? Peanuts, a lot of different food allergies. So typically anaphylactic shock is an easy one to recognize. Patient comes in and their tongue is swollen, and we need to give them something to really take away this massive inflammatory response. And that's when we're going to do epinephrine in the IM form and bronchodilators. Open that airway up. Airway is our biggest concern with anaphylactic shock. We can also use vasopressor support if we're having the problem of that inflammatory response leading to massive vasodilation. And we can give it looks different. We're more concerned about airway than we are perfusion. So it's just slightly different. Oh no, somebody can't hear me. Can you hear me now? Let me just. Okay, perfect. Okay. I cut out for a second. Sorry about that. I was really just saying anaphylactic shock is just slightly different than our other shock states, in that it's all airway concerns. We can have some vasodilation and therefore some hypotension, but we're fixing this with opening that airway. So that is the kind of difference from other shock states where we're mostly concerned about how do we get more perfusion to these tissues. Okay, any questions? Yes, neurogenic shock should be fully reversible as long as that patient can get proper surgical management. And it, like, for instance, if it's a spinal cord injury, if we can restore some blood flow there, if it's a really severe spinal cord injury, specifically up in the higher neck, then it might be more difficult, and we might be having other conversations about the ability for that client to survive anyway. Why would we give steroid admin versus an antihistamine? We could do antihistamines too. Like a Benadryl can work too. I've seen both. I should probably add that into the slide. All types of shock are reversible if caught early on. Yeah, I kind of making sure I'm not thinking through that. Again, yes, if we catch them early on, like cardiogenic, like I said, is the one that if we don't catch it, it can really progress itself in a vicious way. And it depends on exactly what caused the cardiogenic. For instance, if you have that patient that goes into VFib, ventricular fibrillation, they instantly lose their cardiac output. We don't have a pulse. We're now resuscitating them. Something was probably happening that led up to that, that we might not have noticed. So yeah, if we could have caught it early on, maybe it would have been reversible, but I hesitate to say that everything's reversible. But theoretically, if we can interrupt this compensation pathway and help support the patient, then we should be able to reverse these shock states. All states of shock will need fluid resuscitation other than cardiogenic. Cardiogenic is where we need to be really careful with fluid because it can overload the work. It can put a lot of workload on the heart. Tachycardia is most commonly manifestation of shock. How can we be able to know about neurogenic as it's bradycardia? Yeah, so in every other shock state, we see tachycardia. In neurogenic, we see bradycardia. So it's a really good differentiating symptom. When we see that bradycardia and we're really hypotensive and we've got that note of they've had a spinal cord or a brain injury, we think they're in neurogenic shock. Some medication names for examples of shocks. Well, for like when we're starting vasopressors, when we're in this vasodilation state of shock, so any of these distributive ones, they typically are going to need vasopressor support. That's going to look like norepinephrine or epinephrine. There's two other common vasopressors, phenylephrine and vasopressin. But norepinephrine is our first line medication for trying to bring some vasoconstriction to this vasodilation state of shock. As RNs, we can't give vasopressors. We can't order them ourselves. So we need an order from the provider to give vasopressors, but we are managing that infusion. It's a continuous infusion. We're titrating it and managing it based on what the patient's blood pressure looks like. What is medication for cardiogenic shock? That's when we're going to use those inotropic medications, which look like dobutamine, milrinone, and dopamine are our main inotropes for cardiogenic shock. Would we ever need to give vasopressors IV push if they're hypotensive or bradycardic? Good question. Technically, no. Have we done it in practice? Yes. But it's more like a Hail Mary. Sometimes we will push phenylephrine IV push. The only other time that we are using vasopressors IV push is when we're coding a patient and you give a milligram of epinephrine every 3 to 5 minutes. That would be a time that we're doing that when we're actively resuscitating. But typically, no, that's a continuous infusion. Let's see. If I discover there's a type of shock, would I need to call the healthcare provider first, or could I initiate IV fluids? Call the provider first, just to make sure that is an order. Fluid is an order, so you definitely need an order for it. I will say, just working in the ICU for this many years, I have definitely worked on units that they expect you, like if you do recognize this, they want you to go ahead and get some fluid started. But either way, we're calling pretty much at the same time that we're grabbing that bag of fluid. We need a green light for that because fluid is definitely in order. Vasoactive meds that are used in treatment for shock would be norepinephrine and epinephrine. Norepinephrine it being the first line. And then again, if it's that cardiogenic and we need some inotropic support, that's the dobutamine, dopamine, and milrinone. Ernest, or Julianne, I see your message here. You should send an email to support at Archer Review, and we will try to give you some tips there. Okay, everyone. Great questions. I know that was like the quickest review of shock states. I hope that it was helpful. Was this helpful? We might, next time I do this, we'll do it for an hour. But either way, I hope this was helpful. Thanks, Paula. How about phenylephrine? Yeah, phenylephrine's another vasopressor. It is really it it stimulates the alpha receptor in a major way, whereas norepinephrine stimulates it just a little less. The alpha receptor is what's going to cause that massive vasoconstriction. So if we need phenylephrine, we use it, but we like to not need it. It's a really kind of severe medication. We don't send out the slides for these live webinars, but these are saved on YouTube and Facebook. So check there to see this again. I'm so glad that this has been helpful, everyone. Okay. All right. I'm going to go ahead and end it here. Thanks, everyone. We'll see you in the next one. Thanks for letting me